Hello everyone, I am Dr. Prarthan Joshi. I am a urologist, a genito-urinary surgeon. I am working at Zydus Hospital, Ahmedabad. Today we are get to know about a urologist and the branch of urology. What do we do? What are the concerns we address? And who in community should consult a urologist when the need comes? A urologist deals with all the urinary organs of the patient's body, the organs which process urine, which produces urine, transports urine, stores it, and ultimately helps in evacuating from the body. Urologist deals along with the urinary organs, male reproductive organs as well. So let me tell you in brief about what are these organs. The kidney, which filters blood and produces urine, is one of the prime organ we deal with. The urine is produced in kidney, but it is transported down the urinary bladder where it is stored. Both the organs, kidney and bladder, are far apart in the body. So you need a long, narrow tube to transport the urine produced by kidney. This tube is called ureter. So the urine produced by kidney is transported via ureter in a long, tortuous path to the urinary bladder. Urinary bladder is nothing but a bag made up of muscles. So these muscles get expanded and contract within the need of the function. So when the urine is being stored, the muscle is relaxed and expands gradually, and the urinary bladder capacity increases and ample amount of urine is stored so that a person can go many hours without need for passing urine repeatedly. At the time when the capacity of the bladder is reached, it has expanded up to its most possible capacity. The sensation reaches brain and something called as micturition reflux comes into play. Now when this micturition is started, the muscles of the sphincter are relaxed and the muscles of urinary bladders are contracted, and urine passes again through a narrow tube called urethra, and which is evacuated out of the body. So the organs that we deal with for urinary flow is kidney, ureter, urinary bladder, urethra, and urethral opening called as urethral meatus. Now, as I said, urologists also deal with other organs which have function associated with or little different from urine. So we have a couple of hormonal glands that we deal with. One of them is testis, the other is prostate, and third is adrenal. Again, located in a different parts of the body but adjacent to the urinary system. The adrenal, as the name suggests, it is adjacent to the renal, as in on the top of kidney. So adrenal gland has a hormonal function, also responsible for the fight and flight response of the human nature. Adrenal also controls the molecular and chemical composition of the body. It controls the hormones produced by adrenal. It plays a role in blood pressure regulation. Other organs like prostate and testes have secondary sexual function and reproductive functions. So this function of urine process and transport and storage is common for both male and female. The reproductive function of men is also handled by urologists. That's like a branch of urology, what we call as andrology, where the reproductive function of a male patient and the associated disease are treated by a urologist. See that these organs which are specific to men are testis, epididymis, vas deferens, seminal vesicles, prostate, and ejaculatory ducts. So diseases of all these organs that we mentioned, either in form of an infection, inflammation, tumor or cancer, trauma, or obstruction likely because of stone or any other pathology, are dealt with by a urosurgeon. So a urologist or a genito-urinary surgeon does operations or interventions for these diseases. Not all diseases require operations, but for those who require medicine, and when the medicine is not enough, we have to undergo surgery. So we have listed all the organs that a urologist deal with. The diseases of these organs can be either infection, so the infection of kidney like pyelonephritis, renal abscess, infections of bladder, cystitis, infection anywhere in the urinary tract called urinary tract infection or UTI in short, infections of male or female genital glands, inflammation which can be either because of trauma or previous infective episode is also dealt with. Cancer of these organs like kidney tumors, urinary bladder tumors or prostate cancer, which are very common. Some uncommon or relatively uncommon tumors which are dealt with regularly are testicular cancer or prostate cancer. We deal with young kids who require special assistance. Some of the disease a urologist would treat are congenital, as in the disease was present by the time the baby was and the baby's organs were being developed in the mother's womb. Some of these diseases require treatment right away after birth or subsequently. The particular challenge about pediatric patients is the fragile nature of the patient as well as the specialized instruments that we need to tackle those narrow and delicate organs. Most common questions or the most common type of patient that we have is phimosis, that is the skin being adhered at the tip of the penis. Apart from these common conditions, we have pelviureteral junction obstruction or vesico-ureteric reflux. A urologist would tackle young children or infants for their particular need. So congenital problems of the organs that we mentioned like kidney, urethra, penis, testis, etc. They are congenitally developed problems. So the child, when it was being developed in the mother's womb, that is when the problem starts. Some of these problems require attention right away after birth, while some problems like hypospadias or vesico-ureteric reflux, etc. would require intervention at the right time. So the timing of the intervention is very important in such patients. The additional challenge for a pediatric patient or an infant is the availability of the right instruments and handling those precious frail patients. A pediatric patients, either for correction of the congenital deformity or for stone disease or maybe for kidney failure, may require a kidney transplant as well. Now let's talk about male infertility. As I said, along with urinary organs, male reproductive organs and their problems are dealt with by a urologist. A couple with more than 1 year of married life, if develops problems conceiving a child, that is when a urologist or an andrologist comes into picture. Such gentlemen will require thorough examination and some blood reports and semen analysis to identify their problem. Treatment for male infertility can be either medical or surgical corrections. For that, we work in close cooperation with the gynecologists and embryologists. There can be many causes of obstruction, but the most common that we find is stone disease. So a kidney stone, ureteric stone, or a bladder stone can obstruct the normal passage of urine and create the problems. The problems with obstruction is there is accumulation of urine in proximal to the obstruction and the site of obstruction. It can cause infection, inflammation, pain, and any other problems. One of the most common cause of urinary outflow obstruction is BPH, benign prostatic hyperplasia, in elderly gentlemen. So all men have a gland called prostate gland. The situation and the anatomical location of the prostate gland is such that the urine flows through the prostate gland, and with time all men develop some form of prostatic enlargement. It usually starts around 40 or 45 years of age, which is very gradual and usually the patient will not notice the onset of symptoms right away. By the time a gentleman would reach the age of 50, 55 or beyond, that is when they start noticing some form of urinary symptoms. These are called lower urinary tract symptoms, or LUTS in short. These are the symptoms produced by enlargement of prostate causing obstruction of urinary flow. These symptoms include urgency, hesitancy, intermittency, incomplete emptying, increased frequency. If it is nighttime increased frequency, it's called nocturia. It can be secondary to infection like hematuria, like blood in urine, or burning while passing urine, burning micturition. When it progresses further, there can be complete stoppage of ability to pass urine. That is a condition called acute urinary retention. These are all lower urinary tract symptoms primarily caused by an aging prostate which grows in size and causes obstruction to the normal passage of urine. Prostate gland is present in all men. It is a secondary sexual organ. It plays a vital role in the quality and quantity of the sperm in the younger reproductive years in a man's life. With age, the gland itself increases in size. The main problem faced by men because of prostate are three. One is infection and inflammation of prostate called prostatitis. Second is BPH, benign prostatic hyperplasia, which is age-related increase in the size of prostate. And third is cancer of prostate called carcinoma prostate. Let's talk about prostatitis. Prostatitis is by definition inflammation of prostate gland. It can be either bacterial infection or abacterial infection. It can be either acute, suddenly happening, or chronic, which has been ongoing for some time. The treatment options for prostatitis are mainly symptomatic and conservative, as in we don't offer surgery for such patients. The treatment are antimicrobial therapy, mostly in oral form, anti-inflammatory drugs, and other symptomatic drugs whichever symptoms patient has. Rarely the prostatic infection progresses to the stage of prostatic abscess. That is when intervention is required. That is when drainage of such abscess, removing the pus within the prostate, is important. This drainage is either done transurethral or perrectally. Abacterial prostatitis is a peculiar condition which usually affect middle-aged men. This is where either because of previous bacterial infection or other inflammatory response, the prostatic tissue is irritable and causes severe lower urinary tract symptoms or lower abdominal pain or perineal fullness or perineal stretching. This vague group of symptoms trouble middle-aged men, and particularly with normally appearing urinary and blood analysis reports. This group of patients are again treated conservatively, as in with medical therapy. Prostatic carcinoma or carcinoma prostate, when there is a cancer of prostate. Now this is a very heterogeneous group of disease, as in there is a varying degree of severity, varying degree of spread. When the patient comes to us, a patient can be very different from a previous patient. So the treatment is dependent on the aggressiveness of the disease and the spread of the disease that has already happened within the body of the patient. Usually these patients are diagnosed with biopsy, and the diagnosis, once confirmed with biopsy, that is when we do a staging analysis to do either a CT scan, a PET CT scan, or an MRI to know the extent of the disease, how far down it has spread, whether it has spread to the bones or different parts of the body beyond prostate. So once we know the type of prostate cancer and the spread of the prostate cancer, that is when we can decide the therapy. Now, deciding on type of treatment for prostate cancer, some other specialists are also consulted. These are radiation oncologists and medical oncologists. So a team of radiation oncologists, a medical oncologist, and a genito-urinary oncosurgeon like myself would decide the best course of action. Removal of prostate gland in toto along with surrounding lymph node and adjacent seminal vesicle is called radical prostatectomy. That is the standard of cure for an organ confined prostate cancer, whether cancer has not spread beyond the prostate. In case of BPH, benign prostatic hyperplasia, the treatment can be either conservative in form of oral therapy. Medicine, usually patient will take one tablet at bedtime, or a combination of tablets. When the medical therapy fails, or if there are specific indication for surgery, the intervention part is done. BPH surgery is mostly transurethral, which is minimally invasive. Benign prostatic hyperplasia are mostly identified with the group of symptoms called lower urinary tract symptoms. Let us understand what are these lower urinary tract symptoms. Increased frequency. A person would want to pass urine with an increased frequency multiple times a day compared to previous years. This increased frequency can either be daytime or nighttime or both. We have a different terminology for nighttime increased frequency called nocturia. Another symptoms is urgency. Urgency can be identified as a need to go to the or rush to the bathroom once you have the sensation of passing the urine. A person, if we ask to hold the urine for a couple of minutes after having sensation, cannot hold it for long, that is when we can say the person has urgency. Now let's talk about hesitancy. Hesitancy is when the person reaches up to the bathroom and is about to start passing urine but is unable to do so. It takes about a couple of seconds or 10 to 20 seconds before the urine stream is formed. So that is called hesitancy. Person hesitates to void. That brings us to intermittency. Intermittency is when the stream of urine is interrupted and then again restarts. So there is intermittent passage of urine. Then we have incomplete voiding. So when the person passes urine and comes out of the bathroom, they feel that there is some amount of urine is left back and there is a need to go again. That is called sense of incomplete voiding. Now we have burning micturition, that is sensation of burning in the genital region while passing urine or immediately after passing urine. Then there is hematuria or red color urine, which can be because of blood in urine. So these are the symptom complex known as lower urinary tract symptoms. A person can easily self-identify these symptoms if they have it. It is very difficult to diagnose oneself with these symptoms because the onset of the symptom is very gradual, and if you compare your urine flow with previous days or weeks urine flow, there may not be much different. But if you compare the flow with a couple of years or maybe a decade before, one can identify that difference which has been gradually ongoing and increasing. Diagnosis of benign prostatic hyperplasia is done by patients express clinical symptoms, physical examination done by the urologist, physical examination of genital organs, and digital rectal examination for palpation of prostate. Along with history and clinical examination, we do some laboratory tests as well. These are urine analysis for microscopic and chemical examination. We do what is called an ultrasound of KUB, kidney ureter bladder region, which includes prostate as well. We are looking at a couple of things in this ultrasound as far as prostatic enlargement is concerned. We look at the size of prostate, the amount of residual urine, the urine that is hanging back after passing the urine. The volume of that urine is what we are interested in. We also look at hydronephrosis or swelling in the kidney, which can be because of outflow obstruction. Apart from ultrasound, we do a couple of blood tests to evaluate the kidney function, and we also do a serum PSA evaluation in an indicated group of patients. To analyze the quality of the urine stream of the patient, first is the subjective description of the urine stream by the patient, and to objectively analyze, what we do is called a test called uroflowmetry. In uroflowmetry, the patient is asked to void the urine in a specially designed urinary pot, which is connected to the sensor, which tells us how much urine has the patient passed in what amount of time. So the speed and volume of urine passed is presented in a graphical form, and looking at the graphical interpretation along with the other information with the test that we have done, we can come to know the severity of the disease. One of the standardized way of asking the patient to describe their complaints is what is called as an AUA symptom score. So AUA symptom score asks the patient to grade their lower urinary symptoms. So the AUA symptom score is analyzed to see the severity of the patient reported problems. Management of benign prostatic hyperplasia in an early disease form is mostly medical therapy. Patient usually takes one tablet at bedtime, which is more than sufficient for the symptomatic relief. Some special cases where surgery may be indicated right away and medical therapy may not be right are presence of hydronephrosis, as in swelling in the kidney because of outflow obstruction, repeated urinary tract infection secondary to prostatic enlargement, deterioration of the quality of bladder and the bladder muscles in form of sacculations, diverticulum, or urinary bladder stones. So these are the indications for going into surgery right away. Apart from this, most of the patients are managed well with medicines. Someone who has been taking medicine for a couple of years or maybe 5-7 years gradually develops some form of resistance to the medicine, and they also may require surgery at a later date. Surgery for prostatic enlargement are done in a minimal invasive way, that is, there is no incision or stitches involved. The surgery is done transurethral through the urinary tract, and usually patients tolerate this procedure well, and they are symptom free and develop minimal complications. The most common type of surgery done for prostatic enlargement is TURP, that is transurethral resection of prostate. Here we do an endoscopic surgery without any incision or need for stitches. The specialized instrument with a camera on tip goes through the urethra, that is the passage where the urine comes out. We put the camera through that orifice, reach up to the prostate and remove the prostate from the internal lumen. Here the prostate is scraped out either with help of electrocautery, that is what we call as TURP, or with the help of laser. The holmium or thulium laser used here is used to peel away or burn the prostatic adenoma tissue which is causing obstruction. The holmium or thulium laser surgery is called HOLAP or THULAP. So the mechanism and approach for all of this TURP or HOLAP or THULAP remains the same. The energy source used differs a little. When you are undergoing a prostatic surgery, before the day of surgery, we prepare you in some aspects. We look at the body's state to undergo the surgery. We do a pre-operative analysis in form of general physical checkup as well as blood and urine analysis. To look at the cardiac health, one would ask to do a electrocardiogram or a 2D echocardiogram of the heart. By doing chest x-ray, we look at the quality of the chest. Once we are through all the investigation and satisfied with the fitness of the patient to undergo surgery, a date is fixed for the surgery. Patient usually get admitted in the morning with an empty stomach, so 6 hours of meal by mouth or no food is allowed. Food, water or any drink has to be stopped 6 hours before surgery. On the day of surgery, the procedure is done usually in a loco-regional anesthesia called spiral anesthesia, or rarely we can use general anesthesia as well, depending on the requirement by the anesthetic team. After surgery, patient is observed in the recovery area for half an hour and shifted back to ward. Patient usually goes home the very next day, and a urinary catheter along with a urinary bag is kept for 3 to 4 days post surgery. We also look at the histopathology analysis of the tissue that we have removed. Recently, there are newer types of treatment options available for benign prostatic hyperplasia. These are prostatic urethral lift or minimal invasive thermal therapy to the prostate tissue. Rarely, if the prostate is very big or there are other special factors to be considered, we can do a prostatic surgery with help of robotic prostatectomy as well. By and large, in current day and age, and traditional open prostatectomy is rarely done. Patients tolerate this benign prostatic surgery very well and usually are back to work in 2-3 days, and they do not require further treatment. Kidney stone disease is a problem affecting both men and women alike. It is a very painful experience. A stone stuck in the ureter causing obstruction causes severe pain and usually requiring patients to cry out for help. Some of the patients describe the pain worse than a labor pain. Now, when we are looking at kidney stones, there are many names for it. Urolithiasis, meaning a Latin for stone in urinary tract, or nephrolithiasis, as in stone in the kidney. Kidney stones are formed either because of varying degrees of solute and its saturation present in the urine, or disturbance in the flow causing obstruction or altered flow dynamics because of stones or other obstruction itself. Once the stone is formed, it is likely to pass via the urine tract out of the body without causing any problem. When the size of the stone and the location of the stone causes obstruction, that is when the symptom starts. The symptoms of kidney stones are primarily pain associated with nausea and lower urinary tract symptoms. When the stone causes infection, one can also have hematuria, that is blood in urine, nausea, vomiting or fever. In severe cases, there could be complete stoppage of urine outflow or sepsis. The management of the stone depends on the size of the stone, location of the stone, and the amount of bad effects it is causing on the urinary tract and the body as a whole. Diagnosis of renal stone is based on clinical presentation of the patient, the history they give. We do analysis of urine to look for signs of infection, crystals or blood. Because the organs are internal, the imaging technology used for stones are ultrasound, that is called ultrasonography or USG for short. Older times, X-ray was used to look at the location of the stone. Nowadays, we are using more and more CT scans to identify the exact location and size of the stone. as well as the density, which is measured in a unit called Hounsfield unit for the density of the stone. Once we have the complete clinical picture of size, location and density of the stone, affected organs and effect on the kidney function, which is measured through urine analysis as well as blood reports, and presence and severity of the infection. Depending on all the combined factors together, one can plan for treatment. Treatment options are conservative therapy, that is a wait and watch approach. Here we make the patient as much pain-free as possible, treat the underlying infection, and wait for the body to expel the stone on its own. Smaller stones, which are smooth surface, may pass on their own within few days or couple of weeks. It would be unwise to wait for passage of the stone beyond 2-3 weeks because the obstruction can continue to cause problems. When surgery is needed, with advancement of technology, we hardly ever require to do a traditional open surgery anymore. In rarest of the rare cases, we may need to do a open surgery with a big incision and stitches. Most of the time, the stones are treated endoscopically, that is either via small puncture in the back or through the patient's natural urinary orifice. We go up to the stone with a flexible instrument, disintegrate the stone with help of laser and remove all the disintegrated particles. Various terminology are to be known here. PCNL, that is percutaneous nephrolithotomy. Here the surgery is done via a very small incision in the back. The incision is usually 3 to 4 millimeter or at the most less than 1 centimeter. And we put in a scope directly in the kidney, reach the stone, use laser to disintegrate the stone or remove in toto. One other popularly employed approach is per urethral rupture. Here RIRS, retrograde intrarenal surgery. This is for upper ureteric stone or renal stone where the access is difficult with a conventional instrument. Here a highly flexible and maneuverable instrument is used to reach up to the stone through the patient's natural urine tract. Again, when we reach up to the stone, we fragment it, remove the particles. A flexible URS or a ureteroscopy is also employed for lower ureteric or mid ureteric stone, and bladder stones also can be dealt with easily. None of these approach need longer hospital stay. Most of the patient, 99% of patient would be discharged the very next day. An important point to note here is we usually, as a protocol, keep a very thin DJ stent, a double J stent, after the procedure to be removed at a later date. This helps in recovery, it decreases complications and reduces chance of developing post-operative pain or infection. The surgery for stone has become more and more simple, but it is not to be taken lightly because kidney is a highly vascular organ and the infections of urine and obstructive kidney causing urosepsis or urinary infection causes sepsis in the body can be very detrimental to health. So the management overview is, depending on the size, location of the stone, density of the stone, presence of infection and effect of the obstruction on the renal function as well as the overall health of the body can dictate which type of treatment approach is to be taken. Many a times what is being offered is a treatment option called lithotripsy. This is an approach where there is no surgery done. The patient lie down on the specialized instrument and the sound waves are used to concentrate the sound energy on the stone, and the stone is broken from energy transmitted from outside the body. This is called ESWL, extracorporeal shockwave lithotripsy. It is a variation of lithotripsy which does not require surgery, and this procedure is usually done on a daycare basis, as in the procedure takes about half an hour and patient usually goes back home the same day. All these surgeries are done under antibiotic coverage and appropriate pain medications are given to make the patient comfortable. Let's talk about what we should expect after the surgery. Most of the stone surgeries, no matter what approach we take, takes about an hour or hour and a half to complete. The patient is in a recovery area for observation for 30 minutes or so. After that, the patient is shifted to the ward. Most of the patients are discharged on the next day morning. Patient goes home with supportive medication, especially antimicrobial therapy, painkillers, anti-inflammatory therapies. These patients have a JJ stent or a double J tip stent, which is to be removed at a later date. We expect patients to have some form of urinary discomfort or blood in urine for a day or two, rarely beyond that. Patient is asked to follow up after a week or 10 days, and after evaluation on follow-up, we decide to remove the stent maybe on the same day or after a couple of weeks. Stent removal process is done under local anesthesia and can take up to 5 minutes of surgery time and an hour or so of hospital stay. Stone recurrence is possible, and the patients who are treated for stone disease or operated upon are asked to regularly do an ultrasound of KUB region to look for recurrence of stone after 3 months or 6 months of surgery, and thereafter yearly.